If you said B, treadmill stress echocardiogram, you are correct. This patient should undergo cardiac stress testing for functional assessment over heart, but the question is asking you to decide which modality. There are two modalities to think of: the source of the cardiac stress and the observation type, or how the heart is monitored during the test. The types of stress used are either exercise on a treadmill or a pharmacologic stress. The ways the heart can be monitored can be either EKG, echocardiogram, or a nuclear scan. If the patient can reasonably walk on a treadmill for the amount of time needed, then a treadmill stress test is ideal. If not, then a pharmacologic method, such as a dobutamine stress test or a Lexiscan, which uses adenosine to increase the heart rate to the target range, to observe its performance under stress, is ideal. For monitoring, if the patient has a normal EKG at baseline, then a stress EKG is recommended to look for new changes like new ST depressions during the stress. If they have an abnormal EKG at baseline, it would be difficult to assess for EKG changes during the stress, so instead an echocardiogram or nuclear scan are recommended to look for changes that occur during the stress. This patient can walk on a treadmill but has a baseline abnormal EKG, so a treadmill stress echocardiogram is the best option of the choices. Putting it all together, when a patient presents to you with chest pain, your first decision point depends on your EKG. If you see ST elevations in contiguous leads, then you need to be most concerned about a type 1 MI or a STEMI. These patients need to be urgently sent to the cardiac catheterization lab for revascularization. If the EKG has no ST elevations, they could still have ACS, and a positive troponin can help you distinguish between a type 2 MI or an NSTEMI and unstable angina. It's also important to consider non-cardiac causes of chest pain when your EKG and troponin are negative, as some of these can be easily missed. As always, a good HPI and exam will help you determine your pretest probabilities for what's causing your patient's chest pain. Briefly, let's go over when a patient should be considered for coronary artery bypass grafting rather than percutaneous coronary intervention. CABG should be considered when a patient has left main coronary artery disease or when they have significant stenosis of all three main coronary arteries. It should also be considered when patients have significant stenosis of two vessels and a low EF or diabetes. It can also be considered when a patient has severe or symptomatic AS and is being considered for aortic valve replacement. If the patient concurrently has significant coronary artery disease, then a CABG may be recommended at the same time as the aortic valve replacement, so that the patient only has to undergo one surgery rather than two. And that's it for our cardiology review. The NBME will cover more subjects than we can cover in one lecture. So we also recommend that you review EKG tracings of common abnormal findings and arrhythmias. We also recommend reviewing the causes and workup of B and the causes and management of pericardial disease. Thank you for your hard work, and please reach out to the clerkship leadership team if you have any questions.